13 కదండి ఈరోజు.
Okay, 13th.
Good morning all. Welcome to Health and Wellness Series 13. Today we'll be talking about stroke, and Dr. Shaila Pineki will be taking us through the presentation today. And our next session is in 2 weeks. It will be on how to make college search a joy as opposed to a pain. This is targeted towards both parents and students who are going through the process. We'll have some students who are experienced or who've gone through the process will come and talk. And without further delay, I'll ask Dr. Shaila Pineti to take us through today's presentation.
Thank you very much, Rajan. Thank you for setting up and everything too. As usual, we're going to go with the introduction. It's Jet BT Seva. This is volunteering together. This is volunteering together to do service to the community. And this is a service wing under the auspices or under the umbrella of Jet USA, which is started by His Holiness Vidadi Chinnajia Swamiji. This is located at 494 Beverly Rancourt Road in Garimboro. We have these series every other week, either on mental health or on physical health. But some of the activities that BD Seva is involved include, providing education for underprivileged children, blind children as well, education, fundraising for natural calamities such as earthquakes, floods, and food drives. And then of course we have started a new one about offering fresh fruit and nuts, healthy snacks to people who are underprivileged, both in terms of mentally ill patients as well as who are financially insecure and food insecure as well. So we've been doing that every week. And now I come to my topic, which is stroke risk and prevention. Next slide, please. So, what about the incidence? What is the incidence of this? So, we believe it runs 1 in 4, which is 25%, will experience stroke if they're not properly taking care of themselves in their lifetime. So, 12 million new strokes occur annually. And that this works out to be over 795,000 strokes yearly, making it a leading cause of both death and disability. So the disability is a huge economic burden for individuals. It is loss of income apart from taking care of, so there is associated caregiver burden as well. And this incidence is actually rising as we speak because it's also rising in the young adults. All because of the sedentary lifestyle, inadequate nutrition, unhealthy habits, smoking, drugs, and so on. So it's actually increasing, believe it or not, even in the younger population. There are strokes even in a 25-year-old as well. The prevalence is higher in certain population, which includes African American, Native American, Alaskan Natives, and Native Hawaiian and Pacific Islander, more than the white population. And the next slide, please. So what is this is a stroke, we call it as an ischemic stroke. It's a type of a stroke as opposed to hemorrhagic stroke. So what happens is it's basically choking off the blood supply to an area of the brain, and that entails depriving both oxygen and glucose to that area, and basically that area is dead tissue. We call it as a non-viable tissue. So that's what happens. So either because, look how this is a blood vessel, right? And the lumen actually decreases as we spoke. This is the normal size of the diameter of the blood vessel. But what happens is from the cholesterol combining with calcium forms a plaque. So, and this is all cumulative effect. So the cholesterol, all the foods we eat, right from childhood actually, this is kind of cumulative effect. It gradually narrows the lumen. And so what happens is the tendency of a blood clot, or the blood supply clogs, you don't have adequate amount of blood supply because the lumen should be that big. Instead of getting that much of amount of blood supply, you're narrowing it. So what happens is then you actually supply either inadequate amount of blood supply or sometimes it's completely choked off because this is a large blood vessel, mind you. As this branches off into smaller blood vessels and smaller ones, the little tiny blood vessels may not even have adequate blood supply. And that's what happens. See, these thin little blood cells, so that area may not even get. And then what happens is you have a stroke because there's alternatively, it could be actually a blood clot coming from the heart or another artery. Same thing, blocking the blood supply, choking out the blood supply to a particular area in the brain, causing the symptoms. The next slide, please. So the mechanism, that's what I alluded it, is basically depriving oxygen supply, glucose supply to the area of the brain, making it a dead tissue, and then you manifest the symptoms depending on where the blood clot or where the blood supply is compromised. This is usually from a blood clot, but can happen from a cholesterol. Piece of cholesterol can be from a plaque. Sometimes it can be from the heart because your heart has two compartments. One is oxygenated blood and deoxygenated blood. There's a reason why there is a compartment, right? I mean, it's two chambers, you don't want to mix them. What happens is sometimes you bond with this hole which connects the two compartments of the heart, the left and the right side. So usually in the fetus, when you're as an embryo, there is a connection, but as soon as you bond, that hole closes. But in some population, very rarely, like 0.1% or so, the connection still persists, the hole still persists instead of getting closed, and then you have this, what we call as a PFO. So you get from one side to another, and that's a risk factor because one is a high pressure system and the other one is a low pressure system. The blood goes from one side to another, a blood clot can go, and that could be the source of the blood clot. The other one is an infection in the heart, and this is usually seen in people who are immunocompromised, people who use IV drugs. So there's infection that goes into the heart right away, into the valve, and then you have the blood clot going into the brain. Then there is something called an arrhythmia of the heart. So normal heart beats at 72 hours. It's irregular, it's rhythmic. It goes into arrhythmia where you can have an irregular heart rate, such as atrial fibrillation or a flutter, where the heart is not effectively pumping, it just flutters. So what happens is you don't get the enough blood supply, number one, and then the blood pools in the heart and causes blood clots. All of a sudden it reverts into normal rhythm, and then these blood clots, they just kind of go and shower into the brain or anywhere else. But if it showers into the brain, then you get strokes. The other one we alluded to, the plaque gets dislodged and blocks a small artery, and sometimes it goes and blocks a tiny little artery, and that causes stroke as well. It can also be from high cholesterol. I can explain to you, the lumen gets very, very small because of the plaque building up on the sides of the walls, compromising the normal caliber of the blood vessel. Then also can be from IV drugs, and cocaine known to cause, we call it as a vasoconstriction, which is basically it just causes the blood vessel to narrow and causes again the choking of the blood supply to the area. And there are some conditions, inherent conditions, where the blood clotting mechanism is impaired. They have some mutations, they have some tendency to form blood clots easily. And these blood clots could be in the legs, the lungs, and also into the brain. The next one. So what are the risk factors? I think this is basically what we alluded to, but high blood pressure. If somebody has high blood pressure, it's it's imperative that they are compliant with their blood pressure medication. So high blood pressure is a big risk factor. Diabetes, uncontrolled diabetes is a risk factor, high cholesterol, and also smoking. So people who smoke, again, like how I explained the narrowing of the blood vessel, that's even more prominent because it changes the architecture of the blood vessels. Tobacco can do that, so that's why you need to quit smoking. Obesity is another thing, and sleep apnea. Sleep apnea, that's why people who have sleep apnea, it's very important that they actually go to the sleep specialist, get the CPAP, and be compliant with it. Again, heart disease, whether it's a valvular heart disease or it is arrhythmia, again, puts you at risk. Blood clotting disorders we alluded to, and of course, drug use. So what do we do with a stroke? So we have to think fast and really be fast and also act faster. So the moment you realize or your moment recognize, it could be even a layperson walking on the road, if you recognize that, just call 911 because time is brain. So some of the things that you look for in this is we come up with this be fast in the morning. B is the balance. So if somebody is not able to balance, all of a sudden they lose their ability to walk properly. They are kind of walking skewed. They intend to walk straight, so they lose their balance or falling, and they lose their coordination. That's a sign. Eyes. So vision changes in vision, blurred vision, double vision, sometimes even loss of vision or loss of peripheral vision or even visual distortion. All these come under eye changes. Face, they have a facial droop. You see it on one side, obviously. Sometimes it may be very subtle, but it's there. That you have to recognize. And then, of course, weakness on one side. It could be arm and leg, or it could be just one arm, but it's usually one-sided. If you see that, then that's a sign of a stroke. And speech difficulty. Sometimes it could be slurred speech, or sometimes it could be just word finding difficulty, or sometimes it could be comprehension difficulty. All that falls under speech problems. They may not be able to understand sometimes, or even when they speak, sometimes it's not even fluent or coherent, or something like a word salad. Words are there, but they don't make any sense. So immediately call 911 because when you go to the hospital, the sooner you go, the better you can get the medication, the clot busting medication, and the better the prognosis and recovery. So we go to the nearest hospital. Most of the hospitals at least have what we call, they can give the IV medication and we call it as, drip and ship. They drip and then at least send you to the nearest stroke center. But most of the facilities have this IV medication. It is called tenecteplase. It is called TNKs or tenecteplase. The clot buster medication should be administered. That's why time is brain is. It has to be administered within the 4.5-hour window from the time of onset of the symptoms. So the sooner you go, the better the recovery. So even if it's not a stroke, it's better to be safe than sorry. It's better to go to the hospital, get it checked out. So it may not be a stroke, and that's okay too. Next slide. So we talked about stroke. There's most of the times is a transient ischemic attack, meaning that the symptoms don't last. They actually resolve spontaneously within a short period of time. But the mechanism is exactly the same as a stroke. The only difference is the symptoms last from anywhere between 30 minutes to 1 hour to sometimes 24 hours and spontaneously resolve. So this is actually a clinical diagnosis, but when you look at the patient, you won't know whether it is actually TIA or a stroke. It's a clinical diagnosis and the mechanisms are exactly the same as we discussed in the earlier slides. Again, the blood flow is compromised, but it's only for a shorter duration and the blood flow is reestablished, so you don't have the symptoms. Whereas in a stroke, the blood supply is not reestablished immediately and the damage is done, so to speak, so that part of the tissue is dead. Here it is still viable, and that's why when the blood flow is reestablished, the brain tissue is not dead, it's still functional. That's why the symptoms resolve spontaneously. So when you see some symptoms, whether it's a TI or CV, it's better to rush to the hospital. If the symptoms resolve, of course, they're not going to get the clot buster medication. And they can be just worked up. So they still need the entire workup because if TI has happened, transient ischemic attack, they're not immune from having a stroke later on. In fact, that puts them at a higher risk. So it's better to get everything worked out. And they also need aspirin, 81 milligrams for the rest of their life. 81 milligrams of aspirin, believe it or not, prevents strokes, prevents TI, and heart attacks too. And of course, we check cholesterol level. If the cholesterol is high, sometimes even if the cholesterol is not high, we put them on medication. And the reason is not to be a pill pusher, but it's because, we discussed about it previously, the plaque is stabilized with this cholesterol medication. So there are two functions. It not only lowers the cholesterol, but it also stabilizes the plaque. The idea behind putting them on cholesterol, even when the cholesterol level is normal, is to stabilize the plaque so that they're not at risk for having any further strokes. And of course, if the blood pressure is high, we put them on blood pressure medication as well. Can I have the next slide? What are the signs and symptoms? So the signs and symptoms are myriad, really. It depends on where exactly the stroke happens. So different parts of the body are represented on the brain. So brain is only that big. It weighs about 1,000, or it weighs about 1, depending on the size of the patient, but it depends upon, 1 kilo to probably 2 kilos, but it represents the entire body on there. So wherever you have the blood supply is compromised, you manifest those symptoms. So if it's the eyes are gone, then it's just the area that area is affected. So size does matter. Size of the stroke does matter, but it's actually location, because same size of the stroke in a different area cannot even manifest. You wouldn't even know. We call those as silent ones. So you can have a stroke and not manifest depending on where that, because they have a good collateral supply. That is not the only blood vessel that supplies. You have other ones supplying, so you don't manifest any symptoms. So a lot of times, sometimes they get a CAT scan for some other reason, or they get an MRI for some other reason, headache or whatever, and you do see those, strokes. We call them as infarcts, but they're like old ones, and the patient would not have manifested any symptoms. Probably the patient didn't even know, but you just find out that they are there. Incidental findings again. That's because they didn't manifest, because it's the area that's affected did not involve anything serious, and blood supply was probably, supplied by something else that they did not even have any symptoms. So again, some of the strokes have excellent recovery. Some have really devastating ones. Usually the midbrain one, which controls your respiration, your ability to swallow, speech, that usually has much more of a detrimental outcome than some of the other strokes in general. Nothing to bring with stroke, but So, and also the brain stroke, like I said, has poor prognosis, but recovery can vary from one person to another, depending on, where, even if it's the same stroke, the recovery varies from person to person as well. And the person has to be really motivated to engage in a lot of PT and OT as well. Next slide. So what are the symptoms? So the symptoms can vary, like I said, numbness and tingling symptoms can be a sign of stroke. You can have weakness on one side, arm and the leg involvement, or just the arm, or usually not just the leg, but the arm, the face as well. Facial droop is another thing, the acute confusion. And this I would say is very hard to pick up because somebody who's acutely confused, normally they would be using, whatever, their phone. All of a sudden they can't use their phone, they cannot push, they cannot type properly, they cannot use the phone, they cannot use anything. But this happens all of a sudden, as opposed to dementia we discussed last week, it's more of a progressive condition. Slurred speech, speech doesn't come out right. It's very hard to comprehend because everything is so slurred. There's another speech impairment is the word finding difficulty. They cannot get their words out right. For example, if you ask them to, name a clock, they can get the word clock, but they can describe it. They say that it is used to tell time, but they just can't get that particular word. So they can describe the function of those objects, but they can't name the object. Sometimes it's just a word salad. There's no sense. It doesn't make any sense. It's just randomly saying that. And there's also something called as transliteral substitutions. So instead of saying a color is blue, they call it as blood or something like that. It sounds similar, but it is something unrelated to. And of course, the facial droop is there, and loss of vision, sudden loss of vision. Or you could have double vision, or blurred vision, or you could have visual distortions. Sometimes the face, they're watching TV and then all of a sudden the face is distorted, or it is too big or too small, or too far or too near. Those are all the vision changes. Difficulty swallowing, they're choking on even liquids. All of a sudden, happens all of a sudden. Then this particular one is actually a TIA. Most of the time it's a TIA, but it could be stroke too. It's called transient global amnesia. They have sudden confusion. So somebody goes to work, they were fine driving to work. On their way back from work, they drive, they end up reaching home safe, but they don't recall anything, or they cannot account for a chunk of time. They just don't remember anything about it. And usually the caregiver or spouse keeps saying they repeat the same questions over and over again. You answer, but they don't register. And this is usually from an area called hippocampus, which is the seat of memory. So you have a stroke in that, and that's why they have just transient global amnesia, completely don't remember the entire, few hours of their time they can't account for. And they have this repetition, they don't register, right? They cannot able to form new memories. Usually the recovery is pretty good. After a day or two, they are able to account, bits and pieces, they're able to recall the memory. And then you have just isolated hand weakness sometimes, and foot weakness. This is often confused with something peripheral, not necessarily stroke, not necessarily from the brain. When I say it's central in the brain, but you can also have that. Next slide, please. So how do we prevent? So we talked about the treatment. Treatment is that TNK is the clot buster medication, but prevention, like you say, an ounce of prevention is better than a ton of cure, right? So smoking, somebody's a smoker, then quit smoking. Tighter blood pressure control if somebody has, be adherent to your medications, make sure it's under control. Diabetes also needs to be controlled. And then of course the cholesterol as well. Take a statin regularly. Sometimes statins can cause some side effects. Most commonly, you have muscle pain, particularly in your calf muscles. But sometimes you can try a different statin, or you can lower the dose, because some statin is better than nothing. So that's the thing. And of course, you have to take aspirin. If you had stroke, or if you had what we call as a TIA or the transient ischemic attack, taking aspirin 81 milligrams will go a long way in prevention, or Plavix, depending on what your doctor gives you. And then sleep apnea, like I said, I cannot emphasize enough about being compliant with CPAP. If you're obese and weight loss, it's not that easy losing weight sometimes, even though you do everything. Then you have to resort to these medications which are available. The doctor can prescribe if strict diet and exercise regimen is not effective for you. Then of course, if you're an arrhythmia or atrial fibrillation, then you have to be on blood thinners. I know nobody likes medications, but blood thinner will save you, from. But there are other methods of treatment, which is ablation, and also there's something called as a Watchman procedure. Can I have the next slide? So healthy nutrition, of course, is very important. Regular exercise, I didn't refer to that, but that actually is plays a long important role in preventing. Causes again, we referred to that again, uncontrolled blood pressure, undiagnosed aneurysm. I'm sorry. That's not the slide that I was in. Can you go back?
This one?
Yeah, can you jump one more?
Okay.
The one more, next one?
No,
Next one?
previous.
No, next one.
Okay.
Next.
Next, okay.
Let's just jump that one. I think, yeah. Okay. Yeah, so healthy nutrition and exercise regularly actually prevents from having all these conditions. So we talked in the earlier series, I think. Then if weight loss is again refractory, use GLP medications, Ozempic, Mounjaro, I don't know, from the direct to consumers, everybody is familiar with this. But again, I can't emphasize enough about 5 servings of fruits and vegetables daily with nuts, which is alluded as Mediterranean diet, and then balanced diet with protein as well, which is from lentils and soy and other pulses. Then medications, of course, will prevent. So people who have the diagnosis of high blood pressure or diabetes or high cholesterol, they need to take. Next slide. Can you go next one?
Your next one.
Next one, please. Yeah. Okay. What are the stroke mimics? So sometimes it looks exactly like a stroke, but it's not. For example, a Bell's palsy, which is also associated with the facial droop, but is not from the brain. Then there is something called multiple sclerosis, which also mimic a stroke, can mimic that. And then there's peripheral neuropathy, especially peripheral neuropathy involving like a wrist drop or a foot drop and having difficulty walking can often be confused as a stroke. Seizures as well, especially after a seizure, people have what we call as a speech arrest, and that can sometimes be, confused with stroke. Sometimes after the seizure, you can have one-sided paralysis. That can also be confused as a stroke too. So that's why if you see any of these as well, whatever it is, it's better go to the hospital, and that's what the doctors are going to differentiate between the two. So, I think I have in the wrong order. Can you go? We'll come back to it.
Okay, next. Okay.
Yeah, no, the next one. I just have a picture that I have. The last one is a picture. Yeah. So I was going to show you this. It's a normal is, we're not perfectly symmetrical, but this is what a normal person should be, right? You're looking at the nasal labial fold. Sometimes there are very subtle changes, but so it's a stroke, you have this, drooping on one side. You also see the eye is not widened. If it's a stroke, the eye size is normal, and they can wrinkle their forehead, they can raise their eyebrow, both eyebrows symmetrically. Bell's palsy, which is peripheral, which is basically where it's not within the brain, it's called as the seventh nerve palsy or the Bell's palsy. It's named after this guy called Bell. What it involves is the virus attacks the seventh nerve after it exits from the brain. So in that case, the entire face is involved. They cannot raise their eyebrows, they cannot wrinkle their forehead, their eye size is widened on the side that's affected, and the droop is much more prominent, and they also have drooling along that side. So because it's so significant, they have drooling. In some severe cases, their speech is affected too. Not speech, sorry. Their taste is affected too. Sometimes they have some pain around their behind the ear. Sometimes with the Bell's palsy, you can also have everything louder because the virus attack and everything is super sensitized. So you hear things louder as well. But sometimes it's not so much as black and white, it's like a gray zone. So even if you see Bell's palsy, it's better to go to the hospital, get it checked out. That's what the doctors will differentiate. But there is a subtle difference, but you can differentiate between that. That's why I said it's this great mimicker of stroke. Can I have the next slide or go back?
Go back.
Go back, please. Go back. Okay. So all along we've been talking about ischemic strokes, which is what happens from a blood clot. But there are also something called the bleeding strokes or hemorrhagic strokes. So in general, hemorrhagic strokes are much more detrimental with a poor prognosis. But again, just like we discussed about the ischemic stroke being, size does matter, but it's a location. Same thing for the hemorrhagic too. But hemorrhagic actually, the size also equally matters because the larger the size, the poorer the recovery. So blood seeps into that brain tissue. And what happens when you goes into the brain tissue, there is swelling because there is all this scavenger, recruitment of all the scavenger cells to take away the debris, and then there is loss of brain tissue there. So, again, location is critical here, and brain bleeds can be fatal. If it's a large one, it can be fatal. Even if it's a small one in the brainstem, because your brainstem is only that big, it is fatal there as well. So, and then if it's a large bleed, if it's not fatal, the outcome is usually poor. Between the two, in general, it's a much more severe outcome and worse outcome for them, even in terms of disability too. So they have a prolonged and recovery for them as well. The slide before.
Right.
This is it. Slide before. Yeah. So what are the causes for a bleed in the brain? So sometimes it can be traumatic. You're in a car accident and a head injury, and you can have, it's the same thing, right? It's bleeding. So bleeding, traumatic stroke, traumatic bleeding stroke. But you can get it from uncontrolled blood pressure. Like remember, if your blood pressure is so high, now the way the heart pumps, right? So it's a pulsatile flow. So every time if your blood pressure is high, it's just too high to handle for the blood vessel. The blood vessel walls become very fragile, and sometimes it just cannot handle that blood pressure, and then the blood comes out of the blood vessel. But the high blood pressure also puts you at a risk is it's under constant tension, and then what happens is you can have this outpouching of the blood vessel. So instead of flowing in one straight line, there's an outpouching, it's kind of ballooning out, and that's called as an aneurysm. So the aneurysm has much thinner wall, cannot withstand the high pressures, and the blood pressure is high, it just ruptures. And that's what is the aneurysm rupture with elevated. Sometimes you have your born with, sometimes it's a collection of blood vessels and abnormal blood vessels. And they're very fragile because they're an abnormal collection of blood vessels. So normally you have arteries which carry the oxygenated blood, the veins which carry the deoxygenated blood. In between you have something called as capillaries. So capillaries are the ones which actually dissipate the high pressure. So arteries have high pressure, capillaries have low pressure, right? So there are no capillaries sometimes, and there's a direct connection between the arteries, which are oxygenated blood supply, and this. So the high pressure to the low pressure, there's nothing to dissipate. And so this is abnormal collection can easily bleed because the pressure is still high. And that's the traumatic force. Can you do the next slide? Next slide. There. So hemorrhagitis. So the blood, what happens is when a blood vessel ruptures or is it traumatic, you have pretty much the loss area, the blood seeps into the brain tissue, and you have pretty much a larger area, and that's why you have it fills the brain tissue with blood, and when the blood is there, you have all the scavenger cells, your white cells and everything come in. There's a lot of swelling. With the swelling itself manifests a lot of symptoms as well. Sometimes if it's like one half of the brain, say the bleed was huge and it's one half of the brain, there is no other way because your skull is like a vault and the brain is inside. So what they have to do is actually take part of the skull out so that the brain can actually expand out, because even medications can't control it. It is so much of pressure and so much of swelling. Next slide. Yeah. So the management would be when brain is in focus of irritation to the, blood is an irritation to the brain. So it irritates, and what it causes is short circuit sometimes to the brain, and that's what manifests as a seizure. So you have to be on seizure medication. Depending on the size of the bleed, whether or not you put on seizure medication, the doctor decides usually. How long as well, the duration, how long you need to be on the medication. Seizure medication is also decided depending on how large the bleed is. So if it's large, like I said, invariably you're on seizure medications. Probably sometimes forever too, depending on. Then I said the brain swells, it leads to severe swelling sometimes, and the skull flap has to be removed to relieve the pressure. That actually is therapeutic as well for the patient. Next one. Yeah, that's it, I think. I don't have any more slides, right? Yeah. So sorry for that, the sequence of it. I think at the end I did the slides on the fly, so. But I'm more than happy to take any questions or comments. Anyone?
One question.
Sure.
What time of the day a stroke most often happens? Is there any?
That's a very good question. Yeah. Most of the times it happens at night. That's what we call as the wake-up strokes. So we always suggest that aspirin, preferably take it at nighttime, but aspirin has its coverage for 24 hours. But lot of times we recommend is take it at night, because a lot of the stroke patients come in as, I woke up with these symptoms. They woke up in the middle of the night or 4 o'clock in the morning to go to the bathroom, and then they said, I couldn't walk or I couldn't talk. So yes, yeah, they say. For that, actually, wake-up strokes usually we don't give. We need to know the time of onset to give, because the 4.5 hour window is when we give this clotbuster medication, the TNKs. Now, the downside with that is, if you're beyond that 4.5 hour window, the risk of bleeding is higher. Because what if you already have the stroke and then you're giving the blood clotting medication, which is kind of a blood thinner, so you're going to bleed into that brain. So you're causing more harm than help, so we don't give that. So that's why I think wake-up strokes, unfortunately, there's nothing much to do other than, manage the symptoms.
Second question is, the Bell palsy is just like stroke. Is that also all of a sudden, or is it a gradual over a period of several months or maybe?
No, it is sudden. It
It
is
is
sudden, yeah. Most of the times what they say is, "Hey, I woke up or I'm just starting something and all of a sudden drooping." They say, brushing the teeth. I'm brushing my teeth and I can't hold water in my mouth and it's all drooling. That's a symptom they come up with. Or, it's distorted. There's a facial distortion. Mainly this, drooling mouth and all this, drooling one side and face is distorted, yeah. But it looks exactly like a stroke though.
So is it possible, does it happen that the suspect stroke and it wasn't stroke? And
Absolutely, we often see, that's why I said it's better to err on the side of caution.
Okay.
It's better to come to the hospital and the doctors decide. But what if it is, it's very subtle sometimes, a thin line of difference between the two. So it's better to go to the hospital and then get it checked out.
Nice.
Any questions online?
Yeah, I'm just checking the questions here.
Nothing on.
Good.
There's something just.
So, but I have a question.
Sure.
There are risk factors that are modifiable, that are not modifiable.
Right, yeah.
So-
So I would categorize that way, yes,
Right.
that's a good one,
So-
good comment.
Modifiable risk factors that anyone can actually know about and make some changes. What are?
Modifiable risk factors is, again, diet, exercise, not have sedentary lifestyle. And
Smoking, stop smoking.
yeah, stop smoking, stop using drugs, and regular checkup with your primary care physician, especially if you're like hinging on 45s, and that's when things start creeping up. And I think it is because sometimes inadvertently you may be diabetic, it may be undiagnosed, you never know. You may have high blood pressure and not diagnosed, so I think at least once a year, it's a good idea to get blood work, even if you're, in your 40s. Yeah, so, and then I know people are averse, a lot of people are averse to taking medications, but I always explain to patients that taking one pill is better than what the outcome would be, right, if you're not. So those are all modifiable, Even before you get to this high blood pressure, high cholesterol, diabetes is diet and exercise. Okay, that's one category. If you happen to get to that, even with all this, sometimes genetics plays a significant role. So I don't think this can be modified. You get to that, then you have to be compliant with the medication and continue with your diet and exercise regimen. And the third category is where we talked about the arrhythmia. But the arrhythmia also is dependent on, usually most common cause for atrial fibrillation is high blood pressure. So if somebody goes into that arrhythmia, high blood pressure is the risk factor. So those and the non-modifiable risk factors are some propensity to having blood clots, some blood clotting disorders, or if you have a propensity to having suddenly your thyroid is wacky and then you're going to AFib, there's nothing much you can do about it. So those are the non-modifiable risk factors. But smoking, obesity, everything can be controlled. Your sleep apnea.
There is one online question.
Oh, okay.
If one has to rush to the hospital, what is the guidance to make sure it is taken seriously immediately?
Uh-huh.
Good question. You call 911, and most of the 911 paramedics are, just like they are very cognizant with dealing with heart attacks, they are also with the strokes. In fact, when they do the CPR, they do for both, actually. The CPR training, they go through both. So they'll rush you right away. If you see that it's a stroke, and then when you call 911, just say, hey, I've seen someone with stroke-like symptoms, They do everything. I mean, they have to give you aspirin, they have to give you Plavix, they do it right away.
So the question I believe is that will the hospital also take it seriously? Is that
Absolutely.
Yeah.
I don't know about India because I never went to med school in India, so I do not know. But in India, I believe this is very expensive. So, but here everybody gets the same treatment. Nobody is distinct. Yeah.
Okay.
You should always call 911. Don't have your friend or your wife drive to the hospital.
It saves a lot of time because they take you to the nearest stroke center. If you or your spouse or somebody is driving, you may drive to a place where they may not give. I mean, it's a small place if you're living somewhere too far away from a biggest hospital. But in this area, pretty much, I think even if you drive them to the nearest, they can give, like I said, they can drip and then ship you to the center.
I have a question.
Sure.
So, about the transmit ischemic,
Transient ischemic.
Yeah. That one, I know it says it goes often unnoticed, right?
Well, it goes noticed, but it resolves on its own.
Oh, it goes
Yeah, it's only
noticed.
5 minutes or 10 minutes or half hour, you see exactly like the stroke, but even before you get to the hospital, you should still go to the hospital, but you get to the hospital, the symptoms are resolved. But still, even that, like they take it seriously, even that, actually the whole workup is done.
Okay.
It deserves that, it warrants complete workup, so they will do. And sometimes it may manifest as short duration, and then you go to the hospital, you can have, say, a speech problem. It can recur again.
It's something like people with mild heart attack actually go
Yeah.
there, it's nothing, and
So
then
it's
when they go,
angina.
then there is like a massive
Yeah, exactly.
attack or
Because
something
the
like
mild
that.
one, you get to the hospital, you can get a massive one, or if you ignore that, you can get a
Yeah.
massive one and die, right? So, yeah.
Okay.
So the thing is that so even if you have these symptoms resolved, you cannot say, oh, I'm
No,
okay
even
now.
if it resolves, that's why I said, even if it's only 5 minutes, please go to the hospital, because first thing is you get the entire workup under one roof. Because as an outpatient, if you have to get there, you have to wait for a prolonged period of time because you have to wait for insurance approval. They don't approve of the MRI. Now, the TGA, transient global amnesia, is also a TIA, right? But sometimes you can have actually see a stroke in the hippocampus, in the seat of memory. So it is better to go to the hospital to get an MRI. Sometimes the symptoms will resolve, but you may actually have a small stroke. Because the thing with the brain is, there's a specific area which controls one, but the same function can be controlled by another part of the brain. So you may not actually have the symptoms, but when you do an MRI is the gold standard. You will see that. If you have a stroke, you will see on that. CAT scan, they don't. They do the CAT scan invariably is to rule out bleed. Now for the bleeding, CAT scan is the gold standard. So you do the CAT scan, you will see a bleed. If it's a new bleed. If it's an old bleed, you may not see if it's 4 or 5 days. But MRI, you should get an MRI. Whether it's a TIA or a stroke, you should. And then the workup is there, right? They check your heart, we check your blood vessels to make sure, we check your blood vessels in the brain, blood vessels here to make sure there's no blockage anywhere. And if there's a blockage anywhere, that needs to be stented. And the heart too, same thing. If the heart is going into atrial fibrillation, sometimes we may put you on a monitor and send you home. Because during the duration of your hospital length of stay, you may not be, you may be fine. But sometimes you may go into these, into these episodes of where your heart is not working regularly, rhythmic arrhythmia, then that's why we want send them on a monitor, because if you do have even one episode, you don't know when that is going to happen, then you put yourself at risk for stroke, so we have to put you on a blood thinner.
Another online question. If a young person has had a TIA once with optical symptoms, is there a higher risk for stroke in the future?
Absolutely, young or old, if you have a TIA, that is actually one more risk factor. So the risk factors include smoking, diabetes, high blood pressure, high cholesterol, and a previous TIA or a CVA. If it's a CVA, if it's a previous stroke, then it's much more TIAs. But a TIA does not mean, but if someone has just the vision changes and is young, also has to be looked at whether they have any migraines. Because migraines also, I did put in the mimic, but migraine also can mimic sometimes with vision changes. Or for that matter, even one-sided weakness. It's a complicated migraine, you can manifest as one-sided weakness. That's only temporary, but that can also resemble a TIA and a stroke.
So the incidence of the stroke, you said 1 in 4 people. 1 in 4
In the
people.
lifetime,
So if you're looking at a room full of people,
above 45 age. 1
every
in 4
4
above 45 age.
about the,
Age of 45.
yeah. So which means that every person is going to reach. Most people are going to reach 45.
Yeah.
So every 4th person
Can have a stroke or a TIA.
end up having stroke. So the question is has the increased recently compared to the past.
I think so, the
and
stress plays a significant role.
Stress, that's
Yeah.
its main
Because
nature.
stress, what it does is it releases these pro-inflammatory cytokines. Like during COVID, I saw strokes in so many patients. I mean, every COVID patient that I saw had a stroke. Invariably, I did an MRI because even like, COVID, first of all, we are in all this gear. You can get sometimes a comatose too. They are intubated because they can't breathe. You can't get a good exam. So then I used to do an MRIs on everyone, and lo and behold, I saw strokes. And sometimes they manifest symptoms, they don't, because the symptom is a huge surge of these cytokines. These are pro-inflammatory ones, and that can cause hypocoagulable condition, where they have tendency to form blood clots.
So and then under prevention, managing stress is also.
Managing stress, yeah, because
yeah.
managing stress is important, but stress also can lead to hypertension, right?
Hypertension.
And then diabetes too, like it's insulin resistance, leading to diabetes eventually. So they're all like interlinked together. So absolutely, yes. So probably that's why I think 45 is a young age, but if you talk about it, the morbidity and mortality is much better. I mean, if you look at it in the past 30, 40 years ago, people used to die in 40s and 45s from MIs, right? I mean, from heart attacks. So I guess in those days they didn't have stress, but they didn't have the medication, or they didn't have the aggressive. No, they didn't have the aggressive workup, or they didn't have
Access to the medicine.
access to medication, and people were not doing
Advanced
regular
medication.
checkups, right? So people used to die in their 40s and 45s or 50s with heart attacks. So I think the downside is
This aspirin, 81 milligrams, is what they call baby aspirin.
Yeah, you're right.
It's available over the counter.
Yeah, I mean, I think Bayer makes it. You get a bottle, it will last you the entire year.
Yeah.
And there is a study that's done between 81 patients that were asked, is 81 good enough? There's no difference between 81 or 162 or 324. On the contrary, actually, if you take higher one, you're putting yourself at risk at bleeding. So 81 is just as effective as a higher dose. So
Can you start without actually your doctor prescribing it?
yeah,
Because it is available over the counter?
absolutely. If you do have the risk factors, say if you have high blood pressure and diabetes and you want to take it proactive and take it as for prevention,
Oh, I see.
that's okay, as long as you tolerate. Some people bruise easily because it's like basically it's not a blood thinner. That's another misnomer, is people think it's a blood thinner. Plavix and aspirin are antiplatelet. These platelets are the ones that are involved in the clot formation. They clump together and form the clots. So aspirin or Plavix, the two different mechanisms they act through, they prevent these platelets from clumping together and then forming a clot. So they're not blood thinners. Most of the people tolerate very well, unless they have some, gastrointestinal ulcers and they bleed, then that's a problem. But for the most part, people tolerate aspirin.
Good.
Okay.
Thank you. We are only 3 here. Thank you very much.
Thank you. And the person who asked the question also says thank you.
Okay.